Welcome everyone to our webinar around why and how to involve people living with dementia and learning disabilities in research. We've got two great speakers for you today. This webinar is organized by the NIHR Schools for Primary Care, Social Care and Public Health Research, and we've been working together to organize this series of PPI webinars around diversity and involvement, whom to involve. This is the second webinar in the series, and we're very glad that you all were able to join us to learn more about how researchers have really worked with different people to really learn from each other how to do it, and tips and tricks and experiences. So our first speaker is Dr. Jemima Dooley. She is a senior research associate at the University of Bristol, and she's a strong advocate that people who are with lived experience should be included in research, and a lot of her research is around dementia research. So she works a lot with people living with dementia and affected by dementia, and she will share her experience of the work and the impact with us. So Jemima, please, over to you.
Hello, thank you, Esther. Let me just share my screen, share sound. Right. Can everyone see everything? Oh, good, brilliant. Yeah, thank you everyone for coming, and the three schools for inviting me here today. Yeah, this is my favourite thing to talk about, is involving people with dementia research. So yeah, I feel very happy to be here. Yeah, I'm Dr. Jemima Dooley. I've basically just finished a week or so ago a School for Primary Care Research fellowship, and lots of the work that I'm talking about today will be part of that, but also other bits of work that I've been doing as well. So before I get into my talk, I'm going to show you a video of someone who I work with who is living with dementia. He's called John Hyde, and he would have been here today, but he is undergoing surgery, so yeah, a little bit busy. So yeah, he's really kindly done this video for us about his view on why we should include people with dementia. And someone wave if you don't hear sound, but hopefully you should this time.
Hi everyone, my name is John Hyde. I'm 65 years old, and I was diagnosed with dementia about 4 years ago, 2017, 2018, something like that. I've done a few studies to try and help. Obviously don't work anymore and such like, and it's quite a lonely place. Anyway, I've been asked by Jemima if I can do a quick video or something for you, and I'm here to answer the question: should those living with dementia be involved in its research? So hi to anyone who is involved with researching into what many others and myself live with, which is some type of dementia. I thank you for allowing me to bring some words to this project. It's very humbling and at the same time much appreciated. I'll try and keep my input very brief and maybe leave it to some others more gifted in speech to explain what it actually feels like to witness our own humanity drifting away, because basically that's what dementia does. Steals your humanity. You guys have been trying to unwrap these diseases even before the Egyptians, it seems, and you continue raising the bar on treatments and understanding all the time. So, you know, good on you. Right. Well, from us all who live with this, we thank you for your endeavour and your hope for us. And although there is to date no complete cure, you have nevertheless achieved in keeping our candles burning a little bit brighter for that little bit longer. Thank you. being invited to support you with a first-hand view of our shrinking window of capacity will actually help keep our brain cells oiled in some strange way, within our own fate, of course. But it does validate our worth for a while. So the place they call Dementia is a remote town just down the road from normal humanity. It's very frightening and sometimes is hard to find. And we're just beginning to drag this unknown town back into the fold of, humanity. Medicine, through research, has stepped down that road already and wiped away, for the most part anyway, the fallacy and the fear that, for instance, cancer means imminent death. Not anymore. That deaf people will never hear. Not anymore. That paralysed people will never walk. Not anymore. And blind people will never see. But still, when that angel whispers to us the words dementia, we're told instantly we can no longer work, drive, be trusted, have fun, help anyone else, go to the shops, have money, cook dinner, mow the lawn, be normal in any way. And large parts of society continue to send us straight to that village green in that remote town as fast as they can, and wearing our badge of shame we just go silently. So, and why is this even a thing? For me, yes, I can do things. Yes, I can go to the shop still. Yes, I can have fun. I can mow the lawn. Yes, I can be trusted. Yes, I could do lots of things exactly as I could yesterday, or when I was before, I was told. And I know people like you come and visit us in our little town, and you ask me what it's like living here in Dementia Town. Well, just, keep visiting, please. But in answer to your original question, should we be involved in the research into dementia? Hell yes. But nothing more I can add. Blessings to you all. John.
Yeah, basically the rest of the presentation is going to go downhill from there, because I'm not going to be speaking as articulately or as well as John is. But yeah, I think he argued really strongly there why involving people with dementia in research is so important. Obviously, because as he says, it helps people with dementia in lots of ways. I don't have dementia, and I imagine lots of you guys listening don't. But imagine being told something that makes you feel that you were then banished from humanity, as he said. It's just, a really devastating thing to hear, and to feel to stop that feeling is something really important. There is evidence that keeping cognitively engaged does keep dementia from progressing. And, it's really important to make people feel validated, and make people sort of hold on to that kind of self-identity and that self-worth that does so often people report go after they get a dementia diagnosis. But actually, I think that people with dementia, as much as we can help them by involving them with research, they really can help us. And that's what I'm going to be talking about mostly today. They obviously make our research more relevant by telling us what they find important. And obviously that makes it more impactful, which is something we all have to think about as academics. They can increase participation in research by telling us how to design our studies to mean that more people with dementia will take part. And actually, I think that as much as we might validate their work, I find that working with people with dementia can validate my work as a researcher. I think, as researchers, we're doing the general good and adding to the pool of knowledge about whatever we research. But unless you're the person who, invented the COVID vaccine or curing cancer, your day-to-day work, you might not feel that you're making really any difference in life. And actually, I find that the time I spend with the people that I am conducting my research on validates my work. And that's why another reason why I think it's so important. Right, so for the rest of the presentation, I'm going to give kind of 3 examples of different things where I've involved people with dementia in my work and how I kind of went about doing this, and then also kind of finish with some reflections on that. So the first of this is a literature review, which I did as part of my fellowship. I'm sure most of you know what a review is, but the reason why we do literature reviews is to find out what research has already been done and what needs doing. And yeah, as I'm sure most of you already know, there's a very kind of systematic and academic process that we go about doing this. So we have a search strategy where we have defined beforehand specific research question and particular words to use. We then put this into different academic databases. When we have a list of a kind of final list of publications, we extract the relevant information from that. And then we synthesize all of these findings. So we put them all together, and then we have kind of one paper, which is a sort of summary of all the research in that area. And this is a very kind of rigorous and systematic and academic kind of process, and with lots of rules to follow, as I'm sure lots of you are familiar with. So basically in my literature review, I thought, well, it would be interesting to see, I've not done, involve people with lived experience in a literature review before. So it'd be interesting to see kind of how that worked. And that was something that I did as part of my fellowship. So I had a fellowship PPI panel of people with dementia and carers. And I also, for this, involved, I did a kind of remote consultation with Alzheimer's Society service user review panels. So I think it was 7 panels in total who kind of gave me written feedback. And yeah, the feedback was just ridiculously helpful. So lots of my fellowship was kind of based in out of hours primary care, and that's kind of what I thought I'd do my review in. But in talking to them, out of hours seemed kind of less relevant to people than sort of A&E or GPs, and they helped me with kind of different words. And that kind of made my question a bit broader and a bit more sort of encompassing, potentially probably, well, definitely more interesting, more relevant to a wider group. And then I met with 2 of the local Alzheimer's Society SERPs and then my fellowship panel again when I was doing my synthesis. And this was also really helpful. So I sort of came to them with lots of the findings that came out of the search. And they helped me kind of build the themes that I could talk about within that. And it was things that they had also found useful. So avoiding hospital admissions, carers as advocates, but also how carer burnout can lead to emergencies, communication, service barriers and end-of-life planning. So I think this was just a really exciting process for me because it wasn't just kind of PPI that I'd done before in terms of, designing protocols or ethics things. This was actually kind of really in the research process, really in a kind of quite a complicated research process, and it really kind of helped me as a researcher, do that and make sure that it was kind of, more impactful and relevant for people who are living with dementia. The second part that of my fellowship where I included people with dementia was in a conversation analytics study. So that's kind of my background. I'm a qualitative researcher and conversation analyst. And then part of the fellowship was looking at exploring the communication in urgent care. So I was sort of shadowed and video recorded GP out of hours home visits to people with dementia. And I was analysing the communication with the aim to have kind of training points on how to improve communication in this setting, because it's a very complicated, complex setting with various stresses, and obviously dementia can kind of add to that. So the kind of one of the main methodologies in dementia is what are called in conversation analysis, or CA, is called data sessions. So that's where you get together within your research team or within external research kind of groups to talk about the data, to analyse the data, and it's sort of a way of kind of identifying what is of interest within the data. And I thought, well, I could do this with my PPI group, and also with the same so local Alzheimer's Society groups. So I did this, so that sort of were about 11 people with dementia and 5 companions who sort of helped me out with that. Just to give a kind of bit of an idea of what conversation analysis is, for those who don't know, it's a very rigorous microanalytic approach, which really does take years to kind of feel confident and happy with. I've been doing it for over 10 years now. And it's, you can kind of see that this is kind of typical transcript. There's lots of different conventions and things to be kind of, you kind of learn how to use. There's lots of different jargony words on how to describe things. And obviously I realized that the people with dementia didn't have, you know, I couldn't kind of do 10 years of training in half or an hour and a half. So I simplified the approach to the data session a bit. But actually I have to say not that much. I took the conventions out of the transcript. So there's a transcript on the sort of left-hand side. But I tried to keep the rest of the transcript quite similar to what was actually being said. I showed the video in the same way that we would in a normal CA data session, but I added subtitles in case, which actually I did get some feedback from a gentleman with dementia who said that looking at the transcript and the video at the same time was a bit confusing, so you could kind of choose one or the other. And then I just kind of started the meet session with a kind of list of things that would be good to think about while we were watching the different videos. So what are the good things? What challenges are there? Why do you think people are saying certain things? And then I just sort of let them talk. And I wasn't kind of trying to make it as conversation analytic as possible. I was just trying to sort of hear what they said and how they might be able to contribute to my analysis. And actually, I was really kind of blown away with how helpful and engaged they all were with the process. Which sometimes I think, well, why was I really? Because we all analyse communication all the time because that's how we speak to each other. But it was just really, really great. So they did do a lot about talking about their own experience, which I guess is what you expect from a lived experience panel, it was really helpful and sort of helped me kind of think about it. But yeah, I guess that was more what I expect. So they said things like, you know, it must be frustrating for the doctor and for the carer when the patient is communicating. That's what I dread, getting into that situation. So they sort of related it to themselves. They also identified areas of improvement, which was helpful in itself in terms of thinking about, you know, when I want to kind of do training with clinicians. So things like body language. So he said, oh, I think there was a doctor that was sort of stood a lot over the patient. And they said, you know, if you could have easily moved a chair up next to the patient, it would have been a lot easier. But they also made like really quite specific observations, which really were kind of conversation analytic in the thing, in that they really pulled apart bits of the conversation that was happening from the transcript. So this is an example. So this is someone with dementia talking, and they're reading out the transcript. So they said, oh, the carer says, no, it's for she vomits. And then the doctor says, okay. And then they're sort of saying, then the carer talks, then the doctor talks, they sort of count it down. And they're like, the patient's out of it then, there's nothing she can do, she's not part of the conversation. And they really highlighted kind of the point where the person with dementia, the patient with dementia in the video had got kind of marginalized, which was something that I was finding myself analytically interesting. So they were really doing the kind of the conversation analysis work for me, which was just really helpful. So I'm moving on to example 3. This was a project that was separate from my fellowship project. So this was something that we got a very small amount of money for, and from kind of local Bristol organisation called Brigstow, and the Elizabeth Blackwell Institute as well. So it's a kind of £4,000 study, so it was very small, that we did alongside with a group that me and a colleague of mine called Jo Webb is with a group of researchers called the Forget-Me-Nots. And they are a group of researchers who are living with dementia themselves. And we've known them I've known them since about 2017. Joe's worked with them a bit longer because he met them through a PPI panel on an ESRC study he was working on. And this was a project that came completely from them. They are interested in people's experiences in the kind of immediate post-diagnosis with dementia, because that's a time that they struggled a lot with. And they wanted to find out more about that from other people, because they'd all been diagnosed for quite a long time now, and they wanted to see what had been changed. But they really wanted to do research in a way that would be fun and interesting for the participants themselves in the research. So what they wanted to do is, so Harry, he's the gentleman on the left-hand side with the red jumper, he took up photography after his diagnosis, and he found it really helpful. And he said, oh, you know, maybe we could do that with other people. So we put on a photography lesson, and we asked people, essentially a kind of photo voice type study of people to, after the photography lesson, take photos of their life with dementia. And we spoke about it in a focus group. And this was facilitated by the Forget-Me-Nots themselves. I wish I had more time to talk about the photos in more detail, because this project, the things the participants came up with were so insightful and amazing. And I would happily talk about that another time if anyone wants to ask about it. But it was really great. So they spoke, all these different kind of themes came out of it, and we worked together with the Forget-Me-Nots to also kind of analyse that. Yeah, but what I wanted to sort of talk about in more detail was how the Forget-Me-Nots, this being a co-production with the Forget-Me-Nots, was really key to the project's success. So we interviewed the participants afterwards and talked about their experience. You know, the idea of photography as a method came completely from Howie's experience enjoying photography. And this really, really was a positive experience for participants as well. So one of the men with dementia says, oh, you know, it gave me an excuse to express myself. It was a way of opening up. And he was a gentleman. He didn't talk a lot. He was a bit older. He had Parkinson's and dementia. When we met him, he didn't really say a word. But by the end of the focus group, he was really talking through his photos. And this is a quote from his wife, who said, you know, he went and bought a camera because it done him so much good. It was better for him than medicine, which is a really sort of, you know, powerful statement. They also, the participants talked about how having the Forget-Me-Nots there was a really kind of inspiring and positive experience for them. They said it made it easier to take part in research because they said it was a connection between us and you, meaning the researchers. You know, they were sort of translators for us. And people said that, you know, seeing them there was a really sort of gave them a positive outlook for the future. So they said, oh, you know, there were examples of how, even if you've still got some mild cognitive impairment or even some more severe, you can still have a good quality of life. So this kind of co-production method was just really positive experience, really impactful for the project. Right, yeah, so I'm going to sort of wrap up now with some reflections. So obviously the main challenge in dementia, the huge elephant in the room, is the fact that you know, the impact that dementia has on people's communication, on their memory, on their behaviour, also on their physical health, and how that can make already the quite complicated process of public involvement in science more complicated. And I'm not going to go into kind of a lot of detail about kind of adaptations you can make to your own work to involve people with dementia, mostly because yes, basically because everything that I know I've taken from these kind of two resources. So one of these is the Dementia Engagement Empowerment Project, so the DEEP website, which is just amazing. And every time that I'm doing anything with people with dementia, I end up kind of read through my resources again. And they're all kind of co-produced with people with dementia on ways that you can kind of, adapt your kind of normal methods to people with dementia. And also on the right-hand side is the Alzheimer's Society resources. They're also equally good and loads of clear sort of, advice, information. So yeah, I'd point anyone in the direction of those two if they are thinking of involving with dementia. The other thing that I wanted to reflect on was kind of the role of companions when you're working with people with dementia, or sort of carers, as they're sort of commonly referred to. Lots of PPI work in dementia either just involves carers or involves companions or involves people with dementia alongside companions. Firstly, I say there's always try and involve people with dementia if you can. One of the reasons that I ended up going to the Alzheimer's Society CERPs was that I was finding it difficult to recruit some people with dementia into my fellowship PPI panel. And that was a way that I could kind of make sure I could increase the voice of people with dementia themselves. Companions are great in that they can support people who feel less confident. And I think there's a really important role in that. But the Forget-Me-Nots feel very strongly, and other people I've talked to as well, is that actually sometimes they can also inhibit kind of freedom of expression living with dementia. And actually I find that if there's a way that you can kind of set up a co-production or set up a PPI panel where people with dementia can kind of form relationships and support each other, that's a really good way of doing it. So this is a picture from the DEEP website, and they actually have DEEP groups which are kind of for this purpose, which is, it's really worth looking into. But this kind of relates to the last reflection I have, which is to do with how we need to kind of extend our pool of people that we're involved in PPI in general, but also in dementia. So I found, as I just said, kind of existing dementia groups are really useful for me because they provided a structure where I can work with people, with just people with dementia. And so the Alzheimer's Society ones were supported with a facilitator, but they were all, the people within the group all knew each other really well. They were confident, they were happy talking. They were, because they had this existing relationship, which is similar to what we had with Forget-Me-Nots as well. And this, I think, made a bit more of an equal power dynamic at the start because they were used to advising people, researchers like me. And also it sort of saves on time and resources, which we all know is scarce in academia. But I think the problem with using existing groups is that we end up hearing the same voices and we need new faces, we need more ethnic diversity. I think in dementia research, we need older people with dementia to hear their voice and also people with more severe dementia as well. And And I think that the way we just kind of, as dementia researchers, need to make time and have money to address these barriers, really. So this was the SBCR kind of pot that I had to work with groups in Bristol about how we can kind of change these barriers. So that's a photo from there. So I think reaching out to these local community groups and talking is kind of making a start in that. I also advocate talking to other researchers. So I've been thinking about how to include people with more severe dementia, and actually looking at the literature. There are some great groups nationally who are already doing this kind of PPI work in care homes and things. And I think, you know, when I want to do that, I'm definitely going to reach out to them for some tips. And obviously talk to people with dementia about how to do this, which is because they will know best. Yeah, so lastly, so just some final words from the Forget-Me-Nots. Unfortunately, yeah, they've also had some ill health recently, so couldn't sort of say anything today, but these are some quotes that they have on papers that we've written together about their involvement. So they say, you know, when you are diagnosed with dementia, you are told what you are not capable of doing. But the key thing is that there are things you can do, not endless things that you can't do. They said that through research, we've been able to make our feelings felt. We've met other people and we feel empowered. We'd want to say to everyone that research can give you confidence to be able to talk, and it's our time to be opinionated. Yeah, thank you very much. That's me. These are kind of the links to DEEP and Alzheimer's Society, and also John's video, which is on YouTube, and he said that everyone can use and share widely and watch if they'd like to. And yeah, also just the reference the papers I talked about. Yeah, thank you very much, everyone. Stop sharing now.
Thank you very much for sharing your experience, and also for having John virtually talking to us as well. If you have any questions, please do post them in the chat. The first question that we already received was, what was your experience with applying for ethics for this work?
That's a good question. So I guess in terms of PPI itself doesn't technically need ethics. So, but I guess I did have, in terms of the I guess maybe, so if you're talking about in terms of how I showed, you know, sharing the data that I had with the PPI group in the conversation analytics study, we kind of have, say, the people within the consent forms from the video recordings did give consent for the recordings to be shared in kind of a research environment. So that's kind of how we got around that. And then I also, so I showed those quotes from, well, kind of, yeah, from that study, I recorded the CA data sessions I had because I wanted to write a paper on that experience. And then so I also had verbal consent from my PPI group to kind of to publish those kind of snippets. Yeah, I don't know if there's anything kind of specifically more to answer with that, but.
Thanks. And another question was around any project material that you might have developed when for your PPI meeting. So how did you approach that? How did you target it, especially for people living with their with dementia? Were there particular formats like easy read format, or did you have any particular way of structuring it to make it more accessible?
Yeah, so I basically followed exactly what the DEEP kind of advice and instructions were. So things about kind of having, yeah, larger fonts, simple language as possible. I had done a bit of, so I kind of, so I'd worked with the PPI group that I had on kind of designing the participant information sheets and consent forms for the study itself. So I almost cheated a bit because I knew what they liked. So I kind of used similar formats for when I was designing my things for the PPI meetings, kind of from then ongoing, because I thought, well, that's kind of, they see that as kind of clear ways of expressing itself. So that makes sense to me. I have in the past used a kind of, is it readable and things like that online to try and make, I especially am bad at having very long sentences. So that kind of helps me sort of make those sorts of things clearer and shorter. But yeah, mostly using the resources from DEEP in terms of trying to follow that. That's what I do.
Thank you. And we had another question as well. Were there any difficult times during these processes, such as when people were discussing their own experiences, and how did you manage that?
Yes, yeah, I think that there were sort of difficult and emotional times. I think so. One of the, especially, so for example, when I was showing the video recordings with people with more severe dementia to people with dementia, you know, you're sort of aware that that's going to be something that might worry people. And also similarly in the photo voice project, when we kind of would, you know, we're going to be talking about things with dementia. I think it's about kind of starting the group by kind of saying that, you know, this is a kind of safe and confidential space, and to sort of, you know, people, if things we talk about might be difficult for people, we've got to sort of be kind of compassionate to one another and listen and everything. So I think it's about kind of making that space feel comfortable at the start, and then also being I have sort of found it useful that, say, for example, with the photography project, the fact that there were kind of two of us researchers and then people living with dementia meant that kind of, you know, if someone would get upset, we knew that someone, that one of us could go with them into a space, a kind of different space, and talk that through, which is also something that we can do. CAPSI have two brilliant kind of PPI coordinators, so our department in Bristol, so that's something that I sort of can do with them as well if needed. So yeah, I think it's a really good question, and it's just about being aware that these things might come up. And there were definitely tears in all those, especially those two focus groups. So it was, yeah, it can be difficult conversations, but often they're the most kind of fruitful. And that's one of the really great things about these processes, the way that people will open up about their lives to you, and it's just really valuable, I think.
And is there also anything that you do kind of after the PPI meeting, like when, or yourself, or in following up with public contributors when more difficult topics are potentially being discussed?
Yeah, I think so with people, yeah, so if people do get upset, then I will always follow them up. I'll always try and call them the next day and be sort of like, are you okay? And yeah, sorry, I didn't quite hear the question.
No, just like what kind of happens after a meeting, if you know that it was a difficult meeting for people, what you do next? Yeah,
I think just follow up. I always try and follow up after every meeting, just to be like, you know, it was because I think even if people aren't visibly upset, they might or visibly sort of worried about anything, they might sort of and I had very much especially with my fellowship PPI panel, actually, and with the photo voice group as well, we sort of, where it was kind of quite a constant dialogue where we talked quite a lot on the phone and email and things like that. So I always would send people summaries and be like, you know, yeah, if there's anything that you want to talk through on this, is there anything that made you worry or trigger anything, then yeah, I'm always here. And I think that's really important with any kind of co-production work. They're not just meetings and then you know wait a few months and then there's meetings. You should need to have that relationship sort of keeping going to make people, yeah, feel comfortable to open up, and also to make sure that you're caring for those people who are helping you in that way.
Yeah, and I think the last question, what was the impact of the pandemic on your research, and did you need to adapt your work in any way?
It's a great question. I went on maternity leave the day of the lockdown. So although it impacted my life in lots of ways, my research was already kind of on hold anyway. Since coming back, so that kind of, in terms of my fellowship PPI group, it did impact, because it did kind of mean that lots of things I was planning to finish, I wasn't quite able to. And we kind of had phone conversations individually. And I sort of talked to them about the outputs I've had since of the work, so like published papers and things. But I haven't been able to kind of continue with that PPI work in the way I might have had if there hadn't been a pandemic going on. The Forget-Me-Nots, we're still meeting regularly over kind of, it was weekly because we're planning various projects, and now we're kind of 2 weekly as things are sort of, yeah, so but that's moved to Zoom. Which has taken quite a lot of getting used to for the Forget-Me-Nots and for us, and it has been working really well. There have been times where I think, especially one of them, is sort of the confidence has wobbled a little bit with Zoom if things have gone wrong, and then they're like, oh, I can't do this anymore. And I think it is about keeping those relationships going. And luckily, I think now things are opening up a bit. We're sort of hoping to try and meet face to face and stuff, but it has, yeah, it's impacted everything, hasn't it? In some ways, it's nice because it's you know, we have been able to meet more regularly and without the expense or the travel. So they're based in Swindon, so that's sort of about 40 minutes drive from Bristol. But yeah, but on the other hand, yeah, there are difficulties, I think, as well. So yeah.
Wonderful. Thank you very much again for your presentation and for answering all the questions. And then we've got our next speaker lined up, and that's Professor Rachel Fison. She is a professor in social work at the University of Nottingham. And before becoming an academic, she actually also worked in services and providing care and support for people with learning disabilities. So she'll bring all that experience to the presentation today when she talks about working with people with learning disabilities. Rachel, over to you.
Thank you very much, Esther. And I've taken a slightly different tack with my presentation, I think, than Jemima, which I hope is useful for people here. So rather than speaking about a specific project, I'm going to be speaking in more kind of general terms about things that researchers might want to think about if they're researching in any kind of area of public policy, primary care or social care, and want to make sure that they get people with learning disabilities involved in a kind of a mainstream project that's not necessarily focused on learning disability. So I hope that that's equally as useful. Unfortunately, I don't have Jemima's amazing video or anything like that, but here we go. Can people see my screen? Excellent. So I'm going to be talking about both why and how to involve people with learning disabilities. I'm now not sure. So what I'm going to do first of all, it might sound a bit simplistic, but it's just to talk very briefly about what I mean by a learning disability and who are people with learning disabilities. Because this is something I find that people who don't work specifically in the field of learning disability can often get confused about, because there's a lot of kind of contradictory terminology out there. So I'm just going to cover that very briefly. I'll then talk a little bit about the why, but then really focus on the how. So that's kind of the structure of what I'm going to say this morning. So the kind of generally accepted definition that you'll see in kind of public health documents, policy documents, is that a learning disability is a reduced intellectual ability, and that's often taken as having an IQ below 70. IQ is obviously a very problematic measure. I'm not kind of saying this in support of the notions of IQ as being a valid measure, but that is, if you're a clinical psychologist, that is the kind of psychometric test that you'll do. And generally it's if you have an IQ of 70 or below, which is 2 standard deviations below the norm for those of you who are numbers people, that is generally the cutoff point for someone who's likely to be considered to have a learning disability. However, given the understanding that IQ is a kind of is a limited value in determining these things, what the other part of the definition is that as well as having this reduced intellectual ability, that must also result in a significant impairment of social or adaptive functioning. And by that we mean have difficulty to do everyday things. And this must have been present either from birth or started during childhood. So most people with learning disabilities are born with learning disabilities. Some people in certain circumstances can acquire a learning disability. So there are certain conditions, I'm thinking, for example, of phenylketonuria, which is the, those of you who've had a baby and might have had the kind of heel prick when they're born, that's actually testing for PKU, because PKU is a condition where if you're kept on a diet which is free of protein, you will never develop a learning disability. If you are given a diet that involves protein, it creates plaques in your brain, and gradually you will end up with quite a severe learning disability. But most learning disabilities are present from birth. But if it's something that developed during childhood, that's also counted as a learning disability. That, of course, excludes adults who may experience brain damage once they're adults. And that's because the kind of impacts there are rather different in terms of your kind of understanding of the world and your way of being in the world. Specifically, however, a learning disability is not the same as a specific learning difficulty. And by that I mean things like dyslexia, dyscalculia, dyspraxia. Those do not affect people's kind of global ability. They affect very particular areas, and there are ways of overcoming those things. A learning disability is, if you like, a kind of global problem with your adaptive functioning. So just to give you a sense, you know, the different estimates are, but roughly between 1.5% or 2% of the UK population have some level of learning disability. And people with learning disability, so we're talking, you know, 1 to 1.5 million people here. And people with learning disabilities are known to experience worse health outcomes, both in terms of morbidity and mortality. I shouldn't say morality, what a terrible typo there, I apologise for that, than other people. So in terms of kind of health research, I really do think that actually we should be thinking about including this group of people because they are, because they experience such poor health outcomes. But thinking still about who these people are, I mean, the most important thing to understand is that when we use the term learning disability, we're talking about an incredibly diverse range of people. And I sometimes use the analogy to say that, you know, the difference between someone with a very mild learning disability and someone with the most kind of profound and multiple learning disabilities is about as similar as, you know, a person who's stubbed their toe is with a person who's had a spinal injury. And that is the kind of range we're talking about. So when we talk about people with learning disabilities, it is such a broad category that it's not meaningless, but it's really, really hard to say what people with learning disabilities need in any particular situation, because it's such a very, very broad category. And so what I'm going to be doing today is kind of dividing people with learning disabilities up into 4 broad kind of subcategories of people with mild learning disabilities, moderate learning disabilities, severe learning disabilities, or profound and multiple learning disabilities. And those are kind of terminologies which are used quite a lot within learning disability services. But the important thing to stress there is these aren't discrete categories. There's no kind of definitive thing where we can say this person has, you know, a moderate learning disability and this person has a severe learning disability. But I'm going to kind of give you some descriptors to give you a kind of sense of who I may be talking about and the ways in which you might be able to involve people with these different kind of broad types of characteristics in your research. And then the why, I mean, I think I kind of sums it up what I put there in green, you know, don't ask why, ask why not. I mean, I can't imagine why anybody who's interested in healthcare research or social care research would not want to involve people with learning disabilities. You know, they are a significant, numerically significant group of people within our population, and anyone who cares about equality and diversity, anyone who cares about getting a representative sample of the population in kind of big projects, anyone who cares about improving lives, improving healthcare outcomes should be thinking about including this group of people and making their research accessible for participants with learning disabilities. So, as I said before, really I think we need to be thinking about how can we understand what it might take to involve a person with a learning disability in research. And I'm going to, as I said, divide it down into these 4 kind of categories. And as I go through these kind of 4 groups, as I said before, it's not about thinking about these as discrete groups. They are kind of overlapping categories that sit along a continuum. But I'll kind of give a descriptor of each of these kind of broad categories and then say a little bit about the kind of approaches to research that might be more fruitful for these different groups. So firstly, we're thinking about people with mild learning disabilities, and around 85% of people with learning disabilities will be in the kind of mild category. And these are people who are quite likely these days to have attended mainstream school. In fact, these days, almost everyone will have attended mainstream school. People who are of older age groups, people in their kind of, you know, getting close to retirement now, may have been in a special school, or kind of things like reform schools and things like that, if we're going back kind of historically. And younger people, if they did attend mainstream school, are more likely than people in the average population to have experienced exclusion from school. But these are people who are highly unlikely to receive specialist services. And bizarrely, that means 2 things in terms of research. It means on the one hand that in terms of if you want to kind of do research that involves people with mild learning disabilities, then you may well just be involving in your research anyhow without knowing about it. But if you want to target this group of people, they can actually be very hard to find and very hard to identify, because they don't receive any specialist services. And actually what we do know about this group of people is that if you're a woman with a mild learning disability, the most likely reason for you having any contact with specialist kind of services of any kind is if you have a child and then end up involved in child protection services. And if you're a man with mild learning disabilities, you're most likely to be involved with kind of state services if you commit a crime and end up in prison. There's a vast overrepresentation of people in prison with mild learning disabilities. But in terms of kind of health and social care research, I think the main thing to think about in terms of involving this group of people is to think, well, actually, in any research that you do, you should be thinking about how you develop and design your research so that it doesn't exclude these people. Because if you're doing kind of mainstream recruitment, then there is no reason why anybody with a mild learning disability shouldn't be involved, because most people with mild learning disability will be able to give informed consent, and the vast majority of people with mild learning disabilities can read and write as long as kind of plain English is used. And I would encourage people to use kind of readability checkers, and I would encourage people to think really carefully about language. I think, you know, Jemima kind of touched upon this, but really simple things, you know, don't talk about, you know, primary healthcare consultations, talk about going and seeing a GP or going and seeing a doctor. Really simple things that we kind of tend to forget about sometimes when you're kind of so much in a world. We forget how much jargon we use, and we forget how that can make things inaccessible to just any average person in the population. And I would include people with mild learning disabilities as being average people in the population. That they may have kind of tougher lives, they may be more likely to be living in poverty, but in terms of, you know, being involved in health and social care research, there's no reason why they shouldn't be involved alongside any other participants. And you should be thinking about designing research so that it's accessible to this group of people. If we think about people with moderate learning disabilities, this is around 10% of all people with learning disabilities. And these people probably, but not necessarily, attended mainstream school. But if they did attend mainstream school, they were quite likely to be in segregated classes. And when I say probably attended mainstream school, I'm talking about nowadays or in the recent past. People who are older with moderate learning disabilities are more likely to have attended special schools. And of course, if you're asking people about their histories, that can often, you know, where someone's gone to school can often tell you a lot about their background in various ways. People with moderate learning disabilities, when I first started working in this field back in the 1980s, would have been quite likely to receive some kind of support from their either their local health team or their local authority, or indeed many of them may have been living in long stay old kind of what we used to call the mental handicap hospitals. Nowadays, with cuts to services, many of these people may not actually meet the local thresholds for receiving specialist support services. And for that reason, they can be people for whom life is particularly challenging because they have significant needs, but those needs may not always meet threshold criteria. And if they're going to get involved in services, it can often be at a point of crisis. And thinking about involving these people in research, they may be able to give informed consent, although you might want to be thinking very carefully about the language you used and about the time taken to explain things to people. And rather than just using kind of plain English, you might want to be thinking about using kind of easy words with pictures and so on. And if you're not, I mean, I've got some resources at the end of my presentation, but if you're not confident about that kind of thing, then I would suggest, you know, approaching your local community learning disability team and asking for advice from the speech and language therapist, because they often are able to give, you know, really good advice about that kind of thing. These people may sometimes need additional time and support to participate in research, But the key thing here is that issues to do with suggestibility, acquiescence, or confabulation may begin to arise. And I think these things can arise with anybody involved in any research. I don't think this is just an issue in relation to people with learning disabilities, but I think it's something that you need to be particularly careful for. So I think suggestibility, we kind of know what that means. You know, you suggest something, people kind of go along with it. Acquiescence is a bit beyond that. It's kind of where people are agreeing with what you say because that's what they think you want to hear. And I think acquiescence and suggestibility can be things like if you're interviewing people or if you're sitting with someone filling out a questionnaire, you need to think very, very carefully about how you're doing that. So if you say things like, you know, you do like your doctor, don't you? That would be a really bad way of asking the question. You need to ask things much more kind of neutrally. And sometimes you may need to ask questions from kind of two directions. Say, do you like your doctor? Or I'm trying to think of a way of framing that's slightly different. But it's also about thinking about very carefully about which, if you're giving people options between a number of different options, it's about which option you say first and which option you say last. Because sometimes people will always pick the first option that you give them. Sometimes people will always pick the most recent option that you heard from them. So you need to kind of maybe ask things more than once to make sure that someone really was understanding the question that you meant to ask them. And then confabulation is where if you're asking something that's actually slightly too complex for the person to understand, and this can arise with people with learning disabilities, can arise with people with dementia or brain injury. It can also arise with any of us who are in a situation of stress, where if you're kind of asked questions that you're not quite sure the answer of, people try to create an answer they think the person asking the question wants to hear. And so it's not people intentionally lying, but it's people trying to kind of fill in the gap. So particularly if you're using kind of narrative approaches to inquiry, that you kind of think, well, that might be a great approach because we're just asking people about their lives, and it's, you know, it's quite easy for people to talk about their lives and they're the experts in their own life. But sometimes you can ask questions in such a way that people, if they can't remember things, they feel as if they have to remember. And one of the things that can be really useful here is if you think about involving people with moderate learning disabilities in your research as kind of co-researchers or on the steering group, and they'll be able to make really useful suggestions. I remember the first time I did some co-researching with people with learning disabilities, and we were putting together our participant information sheets, and the person said to me, well, we need to say on the participant information sheet about the research that there won't be any difficult questions. And I thought that was a really good example, because it hadn't occurred to me to say that to people, because, you know, it just hadn't occurred to me. And as soon as they said it, it was like, yeah, actually, that is a way of explaining to people that they aren't letting themselves in for something that was going to be beyond their beyond their level of being comfortable with things. Moving on then to think about people with more severe learning disabilities, and around 5% of all people with learning disabilities are classified as having severe learning disabilities. And these are people who even today are likely to attend special school, and they're likely to receive ongoing support from specialist health and or social care services. So they're quite an easy group to kind of find out about and know where they are, but they are a more complicated group to involve in research. Consent is likely to be complex, and I've put some links again at the end in terms of advice about how to think about capacity and consent in terms of research. And consent may be kind of tacit rather than explicit. I mean, it is possible to speak to get a what's the word I'm looking for, to use a best interest approach to getting consent for research. So if there are people who are family members or who work with someone with severe learning disabilities and who can make a best interest decision that it would be good for that person to be involved in the research, that's one way of involving people. But if you have got consent in that way, I think it's really important that as you facilitate that person's engagement, you kind of check in continually. They are enjoying the process and wanting to be there. And that's what I mean about that kind of tacit, kind of an ongoing consent. It's not kind of consent as a one-off thing. It's consent as an ongoing process. But these are people who may have limited verbal communication, and so you may need to think about alternative ways of engaging with people, alternative ways of communication. Some people may use Makaton, which is a form of kind of sign language used by people with learning disabilities. Some people may use bliss boards. There's a whole range of different communication techniques. And again, I would encourage you that if you do want to reach out to this group of people, to find out about individually about their communication needs. And again, to think about hooking up with a speech and language therapist if that was available. And then lastly, I'm going to talk about people with profound and multiple learning disabilities. This is around 1% of all people with learning disabilities. And these are people who are going to need help with all aspects of their of daily life. Most will have no verbal communication. They will have attended special school, and they will be receiving 24/7 care, either from their family members or from public health or social care services. And this is a group of people who often get forgotten about in all kinds of research, including a lot of research that says it's about people with learning disabilities. And I think it is important that we include people with these most profound needs in terms of making sure that services are appropriate and accessible, particularly health services, because these people do have often very high and very complex health needs, and it's important that they can access the health that they need and deserve. These people are unlikely to be able to give any form of traditional informed consent. And, you know, as with Jemima speaking about involving people with dementia, the way to involve people with profound and multiple learning disabilities may in some cases be through kind of mediated involvement via a carer. And it's also important, though, to understand that actually there are ways of collecting information about this group of people by asking others to observe things, by thinking about trying to, rather than frame things in terms of asking people's questions about things, which you can't really do because these are people who don't really understand kind of abstract questions, but you can ask people to express preferences between particular choices, between particular different things. And so there are ways of finding out from this group of people about which things they preferred or found more or less difficult, and so on, in terms of their experiences of services and situations. And there's a really great project that I was kind of proud to have some small involvement with that MENCAP ran a few years ago called Involve Me. And that was all about how to involve people with profound and multiple learning disabilities in kind of not just research, but in kind of thinking about how services should be run. And then one of the kind of resources I've got on the next slide is about is to that website. So my kind of general things to consider about involving people with learning disabilities in research. The first thing is about language. You know, really work hard to avoid jargon. You know, go and speak before you even get as far as trying to check with someone with learning disability about the language. Go and find a friend who does not work in health services and does not work in social care services, and ask them first of all to point out the worst of your jargon before you then take it to people with learning disabilities. Add pictures if possible. You'll have noticed that all of my slides today had a picture on the left-hand side and words on the right-hand side, and that's very deliberate. There's kind of been research done, not least by probably colleagues that Jemima may know down in Bristol at Nora Fry Research Centre, where I also had the privilege of working for a number of years, to show that when you're doing kind of easy words and pictures, you need to put the picture on the left-hand side and the writing on the right-hand side, because we all read in the UK from left to right. If you put the pictures on the right hand side, it looks to people like an afterthought. Whereas if you put the picture first, they engage with the picture and then move on to look at the writing. So little things like that can make a difference to how people perceive the information that you're trying to share with them. And do add pictures, so do use pictures with your words if possible. Check the readability of text. There are lots of free readability things online. And consider using alternative formats. You know, nowadays making a video is so simple. You know, all you need to do is, you know, get your smartphone out. You don't need to do anything fancy, and speak into it. And then people have got a video that they can look at of you rather than having to read something. Those things can really, really make a difference. And then it's about being proactive. It's about thinking about paying people for their time. It's about actively trying to target this group of people to involve them in their research. It's about reaching out to people with learning disabilities, involving them on research steering groups. And then sometimes they're thinking about kind of third-party participation via carers. And then those were my kind of further sources of information. The first two are the first one is NHS Digital, and where they have a collection of data for those of you who are number crunchers about people with learning disabilities. The second one is the Leader Project, which is all about the deaths of people with learning disabilities. Sounds rather grim. It is rather grim in some ways, but the project is all about learning from the deaths of people with learning disability and autism, and about what health and social care services could and should be doing differently. I've then put just a link into a readability test to advice from the NHS Health Research Authority about mental capacity when it comes to research consent, some information from one of our leading learning disability groups about how to make information accessible, and then a link to the MenCap Involve Me site. I'm going to stop sharing my screen now, and thank you very much for listening.
Thank you very much for that, Rachel. Very interesting to hear about different categories and different nuances in involving and working with people with different types of learning disabilities. There are some other resources already being shared in the chat as well. If you do have any questions, please do post them in the chat. We had a first question already coming in, and that was around recruitment of people with mild learning disabilities. And do you think it's worth going through the college route to recruit people with mild learning disabilities to research projects and advisory groups?
I think that's always can be a good place to start, because certainly the kind of FE colleges, there will be courses there for people with mild learning disabilities. A recent PhD that I supervised, it wasn't on health stuff, it was about actually employment for people with mild learning disabilities, and that took a huge amount of effort to recruit people. It was really, really tough. And actually we found that although I've been using the term learning disabilities, actually in that we found that actually people preferred the term learning difficulties. They found that easier to be recruited to. We used posters in libraries, in GP surgeries. We did get a few through colleges, but not a great number. But I would say in terms of mild learning disabilities, they're more likely to be people who are involved in your research anyhow. You just need to be making sure that your research recruitment materials and your participant information materials are accessible to people who have mild learning disabilities, rather than necessarily actively targeting them.
Thank you. And do you feel that stigma is a barrier as well, kind of in all of the four groups that you're talking about when thinking of recruitment?
I think stigma is if you label it, I think stigma is a big barrier for people with mild learning disabilities. I think it's less of a barrier for people with moderate, severe or profound and multiple learning disabilities, because I think those people are more aware of, and to use a kind of sociological term, kind of drawing on Goffman, they're less able to pass. So they're people who are people with mild learning disabilities often put either intentionally or just through how they've always been in the world, a lot of energy and effort into covering their difficulties, and may not wish to be identified as having a learning difficulty. It may be in a source of shame, embarrassment, discomfort, difficult experiences during their educational, during their school years, and actually they want to move away from that and not think about it. So it may not be a good recruiting kind of, unless you're specifically trying to look at that group of people, it may not be a kind of recruitment point. For other groups of people, there are even that they are more likely to be linked in with services in different ways, or even if it's just like, at support groups and that kind of thing. And I would suggest, every town and city will have different organisations that provide support to people with learning disabilities, and many of them, if you approach them, will be happy to be involved in kind of supporting their group members to be involved in research, if you approach them in the right way, and if you offer the right, if you are approachable, if you fit in with them, if at all possible, if you offer payment for involvement, either to the individuals or to the organisation.
Thank you. And then another question was, do you have any tips for helping encouraging ethics committees to allow participant information sheets that are less off-putting for people with lower literacy?
That's a really good question. I mean, I have had, participant information sheets that are in pictures and simple words approved by, the kind of, the main NHS ethics committees, and they haven't found that a problem. I think that's probably because I was doing research on social care. I can see that things might be more challenging in terms of healthcare, and I think that speaks to a bigger problem, because I actually bizarrely have more problem with my university's ethics than I have with the external ethics, because they want me to use the university form, which I think is absolutely appalling, and it's too long-winded, it asks too many questions, it's phrased in language people don't understand, and it's really there to cover the insurance of the university. And I find it incredibly unhelpful, and people don't read it, they just sign it. And I think it's a battle we need to have generally with lots of, in terms of ethics. The ethics should be about, I'm probably being a bit outspoken here, I often fear that ethics is more about covering people's backs than is about what I call genuine ethics, which is about making sure that participants understand what it is they're being asked to do, and making sure that they can give genuinely informed consent, and making sure that ethics isn't just a process that you do at a particular point at the start of your research, but ethics is something that infuses everything you do throughout the research project, including how you gather data from people, how you work with the data once you've collected it, and how you present findings. So yeah, I have a bit of a bugbear about ethics committees, perhaps.
Can I just jump in on that one from like a practical thing that I've done before with ethics, is that you have like a easy read, clear, sensible thing that will actually be read and used, and then you have like a longer one which has all the GDPR wording that they need and the whatever, and ethics has said that's fine, and you kind of know as researchers in reality that second one probably won't be read, but at least you've covered your back, and so you show that you've done the tick box that they ask you to do. I completely agree with everything Rachel just said in general about ethics, but yeah.
But that's where I find it problematic, because it is literally, it doesn't do anything for the person who's involved in the research, it's covering the back, and I find that really problematic, but we have to do it. Yeah.
Thank you. I'm mindful of time, so just one last question. And that is, someone raised that they have experiences in medical schools where people have just excluded or tried to exclude people with learning difficulties by default when planning their studies. And what would you recommend someone who wants to be an ally towards their colleagues to kind of challenge their decisions?
That's a really good question. I would say ask them why they're doing that, and point out to them that if they really care about health outcomes, then what they're doing is excluding an already disadvantaged group. And why would they do that? We wouldn't, and ethically and morally, it's not acceptable to do that. We wouldn't say, oh, I'm going to exclude all black people, or I'm going to exclude all gay people, or I'm going to exclude all, you know, we just wouldn't do that. And so why do they think it's okay to exclude people with learning disabilities, especially those who are able to give consent?
Wonderful.
So that would be my argument with them.
Thank you very much. So thank you very much, Rachel and Jemima, for your presentations and for answering all the questions. And also thank you to Michelle, Mike and Katie for helping in organize this webinar. There will be a third webinar in this series later this year, so do keep an eye on the social media and website of the 3 NIHR schools if you're interested in participating in the next one as well. Have a good afternoon, everyone. Thank you for joining.